look for response to methimazole. If the methimazole response is not there, age is less than 5 years, if the child has a large goiter, the only option is surgery. If it's more than 5 years and the size is more than 80 grams, again surgery is recommended. Less than 80 grams, radioactive iodine may be considered. If, however, you have a good response to methimazole, assess the risk factors, the thyroid size, the age, the gender. As I said, large size, male gender, very high FT4, and TRAB is high, suggests that there will be a high chance of relapse in that regards. So if they are not there, you stop after 3 years. If, however, it is there, then you should ideally stop it after 5 years. There is no hurry in that regards, and then go for remission. If you do not achieve remission, then you go ahead with a definitive therapy in that regard. So initial treatment is methimazole, and then based upon clinical response in age, you can decide about how do you want to go further from that regards. In relapse, again, you have to monitor, and then you go ahead with a subsequent therapy in terms of the definitive therapy. So, Dhwani, 12-year-old girl with tremors, FT4 is 34, TSH is very low. She has swelling but no eye sign. Tremor is there. What do you think is the likely diagnosis? Yeah. Sure. So this is one scenario you have to be careful about, and you may think of going for a thyroid scan which showed a Graves' disease clearly. So treatment plan, methimazole was given or PTU. Which one will you like? Okay. So definitely these are the various options available. You will like to go ahead with methimazole there, and you will see for the response in that perspective. Now on methimazole, 30 milligrams, she developed sore throat. What will you do? So we'll stop the drug, look for CBC and antibiotics. TLC was 4400, which means that this is a normal sore throat. So it's not that everybody will have a agranulocytosis. So in this regard, you can restart. Very important, first 100 days, the effects is there 0.3%, which means 1 in approximately 300. So it's a reasonably good chance. Now, Dhani, on follow-up 2 months, FT4 is 12, which is on the lower normal side. TSH is low. Will you increase the dose? So as I discussed very clearly in that table, that even if your FT4 is normal, you have to reduce it by 50%. If the FT4 is low, you reduce it by 75% after the first visit, and TSH has no role here to identify. So this is the scenario we discussed. So clearly you should reduce it by around 50% in that regards. Dose reduced to 20 milligrams. After 2 months, you find FT4 is 4 and TSH is 3.4. So FT4 has come on the lower side and TSH is normal. Decrease the dose. So this is again, now this is looking like a central hypothyroidism clearly. So what's happening is that if we had decreased the dose even further, we would have been better. That's what the message is. So if the TSH is low, don't worry about it. FT4 is a much more important. It was much higher. I think it was 34 or something. Then it became around 12 and now it's come down to 4. So this girl, if you leave it like this, will develop profound hypothyroidism very quickly. So we reduce the dose to 10 milligrams. After 2 months, what we are seeing here, she is only on 2.5 and FT4 is low, TSH is 12.8. So I think this is clearly a scenario that she's probably entering into that phase. And as I said, if you have a high chance of remission, you tend to stop it around within 3 years of therapy. If on the other hand, there's a less chance, you can continue up to 3 years. So if at 2.5, this is the level, I'll definitely stop it at this point of time. So this is an indication where we have to think of stopping the treatment, but there could be a chance of recurrence. And she again had recurrence. And then in this scenario, radioactive iodine would be the ideal scenario. Now, FT4 is 18 and follow after 2 months, TSH is less than 0.5. So I think this was after the radioactive iodine. So how do you interpret this scenario? Yeah. Yeah. So this is often which may happen. If immediately after that the level is not that high, you can wait. Otherwise, you can give them beta blockers in that regards. Now, after the second dose, the FT4 has come really low and TSH is high. So she's now gone into a permanent hypothyroid stage and you start on thyroxine. What TSH will like to maintain in this scenario now? On follow. Yeah, so 0.5 to 2, something like that you want to maintain. TSH, not the FT4. Yeah. 4-year-old girl with tremor, FT4 is high, TSH is low, small goiter, increase uptake is what we have seen in that regards. What do you think should be done? Yeah, this looks like Graves. Diffuse uptake. There is a goiter also. So this is like Graves' disease only. So which drug will you start? Yeah, so clearly you'll start with methimazole in that regards. 15-year-old girl with thyrotoxicosis, FT4 is very high. TSH is less than 0.01. There's a large goiter and an eye sign. Now, in this scenario, of course, we have seen that this is something which we have to be very wary about. And when we are saying large, it's like a big goiter often. So you have to control and then you can think of go for surgery in that regards. First, you give methimazole or Lugol's iodine in that regards. 17-year-old girl with neck pain, FT4 is mildly elevated, TSH is low, there is no goiter or eye sign, ESR is 100, and somebody got a scan which shows a reduced uptake. So what is your diagnosis? Yeah, so this is subacute thyroiditis and there is tenderness. So your treatment would be? So you will give a course of steroids and prednisolone and beta blockers. 8-year-old boy with throat pain. Again, this is what we've discussed, severe tenderness, and you will find abscess which is there. So this is an extremely severe condition, and often you may have an underlying pyriform sinus which is there.